I would like to welcome all of you to this unique program today, which we are doing for the first time in the All India Ophthalmological Society. And this is being done by HOYA, and it is the Masters Film Festival. And we have the Masters on the dais, and I would request Mr. Yuri to please play the introductory video. So we are delighted to welcome you to the Masters Film Festival presented by HOYA Surgical Optics, an innovative video-based educational platform dedicated to clinical excellence. Today, we have the privilege of hosting 5 distinguished masters who will showcase groundbreaking insights from 5 unique ophthalmic practices around the globe. We are honored to be joined by our esteemed panelists, Dr. J.S. Chityal, Dr. Mahipal Sachdev, and Dr. Sri Ganesh, who will engage in dialogue with a distinguished lineup of speakers, internationally renowned pioneers like Dr. Richard Packard and Dr. Eric Mertens, alongside leading voices of the new generation, Dr. Ashwin Agarwal, Dr. Supriya Sri Ganesh, and Dr. Shreyas Ramamurthy, to help shape the future of ophthalmology. Throughout this session, we will highlight 5 exceptional clinical practices exploring cutting-edge techniques and their transformative impact on modern cataract and refractive surgery. We look forward to an engaging and insightful experience. The meeting has been structured in such a way that we move from younger patients who require us to apply more refractive mindset through to the older patients with specific complications and pathologies which test our surgical skills. So please join us on this journey. Now let's focus on presbyopia correction. We'll begin with a video from Dr. Eric Mertens, who established his multidisciplinary clinic, Medipolis, in Antwerp, Belgium, about 15 years ago. Eric is not only recognized as a leading European expert, but is also highly respected internationally. Today, he will share his process, which has helped him to achieve optimal patient outcomes, which sustains his premium, highly optimized and efficient practice.
My name is Eric Mertens. I'm based in Antwerp, Belgium, and I'm a corneal and refractive surgeon. When patients come in for a pre-op evaluation, they get welcomed at the reception, where the secretary does some measurements like endothelial cell counts, also the autorefraction and the intraocular pressure. Then the patient is positioned in the waiting room, where the optometrist welcomes also the patient, starts with the anamnesis and tries to find out, are there any medications they're taking, allergies, what is the lifestyle, what are their hobbies, what are they doing in their daily life. Then the optometrist accompanies the patient for more specific tests like corneal topography and also aberrometry to look for abnormalities in the cornea and in the optical system of the eye. Whenever we see abnormalities in the tear film or in the epithelial thickness map, these are always first treated. The patient goes home and comes back, let's say, in 4 to 6 weeks to redo the test. Only when those measurements are perfect, then we rely on the measurement done by the biometer, because then we are sure that we can order the right dioptrical power for that trifocal presbyopic correcting IOL. When all tests are done, I have a look at them and I make a decision which type of IOL is the best choice for this patient. Then I discuss with my patient coordinator what she or he should explain to the patient. After the explanation is done, which takes about 20-25 minutes, then the patient comes to me for the final discussion, if there are any questions remaining, and also they can see me before we have an appointment for the surgical intervention. So in most cases, when the eye is suitable, I go for a full range of focus IOL, which is most of the time a trifocal IOL. So the geometric family has the geometric and the geometric plus, which give the patients a continuous vision from distance, intermediate and near. And so by pairing the geometric and the geometric plus with different light distributions, because they're both trifocals, this gives a very smooth transition from near, intermediate to far vision. In other instances, when we have an irregular cornea, irregular astigmatism or scars, I sometimes go for a real EDOF, so a small aperture IOL. And in other cases where we have not an optimal quality of the cornea or not optimal quality of the retina, I would go for an increased range of focus IOL. At the day of surgery, the patient is welcomed by the same patient coordinator as they saw at the pre-op examination, so they feel already confident, they feel in a nice environment. Our patient coordinator explains how it looks like the surgery, how long they will stay in our clinic, which drops they have to use after the surgery, and also which appointments they have to come day 1 and 30 days after surgery. This is our routine looks like this. Into the surgery room to achieve success with this type of lenses I'm always using the femtosecond laser. Why? Because the centration of the capsular rhexis is at the highest point of the lens capsule, which assures a very nice centration of these full range of focus IOLs. On top of that, the femtosecond laser can achieve markings on the cornea when treating astigmatism. I typically use the geometric toric and the geometric toric plus lenses from 1 diopter onwards. Below 1 diopter, I use the accurate keratotomy incisions of my femtosecond laser system to achieve astigmatism neutral outcomes after surgery. During surgery, I try to achieve an astigmatism neutral incision as much as possible. That's why I'm sitting always temporal, and I use a 3-step incision technique. Another important pearl is that I always put my incision at the limbal vessels. Why? It's bleeding a little bit, which means the incision closes faster, heals faster, and it's proven by the peer review literature that you have less endophthalmitis by this approach. It's very important to clean the back. That's why I take great care in cleaning not only the posterior capsule, but also the anterior, which makes it very important that the shrinkage of the back is not too excessive. And the presbyopic correcting IOL is and stays nicely centered in that capsular bag during the 3-month post-op period where we know the capsular bag is shrinking. When dealing with toric presbyopic correcting IOLs, it's of course very important that the astigmatism is corrected at the right axis. Therefore, we use 2 systems. One is the markings of the femtosecond laser on the cornea, and on top of that we have a digital system overlaying my microscope image, so I have a double security, as I may say, that I know that I'm putting that toric correcting IOL at the exact axis I want it to be. Since many years, my approach is a bilateral sequential lens surgery because, first of all, the patient has to come limited times to my practice. But what is most important is that both eyes are corrected, so the brain gets the images from day 1, the same images from both eyes. In the past, when I was not doing that, all patients were complaining of that sometimes double vision, sometimes they get some headaches, and they were not satisfied with the results from the first eye because the brain was confused. For all those reasons, it's in the interest of the patient to do both eyes at the same time. So after surgery, the patient gets sunglasses because they're very sensitive to light. They go home, We do not patch the eye, we do not use eye shields. They also sleep without eye shields because of that 3-step self-sealing incision. We did not encounter any problems. We see them on post-op day 1 and post-op day 30 approximately. And of course, we are available. They can phone us 24 hours a day whenever they have a problem. So I hope this video was very helpful in using some tips and tricks for your patients and to achieve more success when treating patients with these presbyopia-correcting IOLs.
So thank you, Eric. I think that was a great narrative. I just have a question for you. Your setup and workflow is truly impressive, and the percentage of patients looking for lens replacement and receiving a trifocal IOL in your practice versus other options is very high. Why do you think it is? And does that mean that you experience more problems as a result of this?
Yeah, thank you for that question. I think a lot of our colleagues are bringing in patients and upselling their procedure, meaning that they want to attract a lot of patients with a low price. And patients come in, and then you have some dry eye, we have to treat it, it costs an extra. Oh, you have astigmatism, it is an extra cost. Or you want to get rid of glasses for near, and for distance it's an extra cost. So they're upselling the procedure. And as you and I imagine, are encountered with this kind of strategy, I feel very uncomfortable. I feel like, they're going to trick me. So we have a completely other approach. We downsell our procedure. So, and that needs another mindset in your practice. The whole team has to be fulfilled with the idea that every patient is a full range of focus IOL candidate unless proven otherwise. So we are downselling the procedure. We have also one price for that premium category. Whether they need a treatment for dry eyes or astigmatism correction, it's all the same price. I'd also get, when they need some omega-3 pills, we provide them free of charge. By doing that, we are very successful with that. And also the patient has a lot of confidence in what we do, because we are not charging extra for other procedures. And when we deal with like retinal problems or glaucoma, we send them first to our retina specialist or a glaucoma specialist to see whether they are still a candidate for that full range of focus or not. So by doing that, they feel a lot of trust, and we do not encounter more problems than I think other practices in doing a lot of those full range of focus IOL patients.
So essentially it is more important to do a good pre-op evaluation so that your outcomes are optimal. Dr. Sri Ganesh, would you like to comment on this? Why is geometric pairing the preferred approach?
Among the trifocals, I think the geometric and geometric plus has a very unique design, and it's one of the few platforms, or I would say the kind of only trifocal platform which has this differential light energy and light distribution. And because of this, vision is binocular. So you should look at vision being binocular, and then you can adjust the light distribution differently in both eyes to give a full range of vision. And this improves the patient satisfaction. The geometric, the focuses for distance, intermediate, and the light energy is slightly less for near, whereas the geometric plus, the light energy is more for near, intermediate, slightly less for distance. So they kind of balance each other to give a full range of vision, and it is a pupil dependent lens. So the diffractive zone is in the 3.2 millimeter, central 3.2. So at night when the pupils dilate, then the more light is coming in from the refractive part, which is for distance, and this also reduces the amount of dysphotopsia. So this pairing approach is very unique, and we always do the geometric for the first eye. So we don't look at dominance. The geometric is done for the first eye, and then that is because the patient always appreciates distance vision. If you get your distance vision correct, then the patient satisfaction is very good. And the second eye, we do a geometric plus. So this is a pairing approach. Again, this is not like a monovision, and it is, don't look at it like monovision, don't do a dominance test. It's differential light distribution. So even if you put the geometric plus in the dominant eye, there will not be any issues. But the first eye that you do, I always prefer to do a geometric, and the second eye the geometric plus.
Thank you. Now let's learn from our young participant, Dr. Supriya Sri Ganesh, the Executive Director, Leading Cataract and Refractive Surgeon at Netradhama's Super Speciality Eye Hospital, Bangalore. She is actively involved in research, training and education. She organizes programs like NERDS, iView and NZRSC. She is also recipient of multiple national and international awards, including the Best Paper of the Session at APA-CRS 2024. In this video, Dr. Supriya will share how she achieves spectacle independence for her patients, walking us through the patient pathway towards advanced vision and enhanced post-surgical quality of life.
Hi, I'm Dr. Supriya Sri Ganesh. I'm a consultant cataract and refractive surgeon at Netradhama Super Speciality Eye Hospital in Bangalore. I do about 2,000 cataract surgeries a year and 500 plus refractive surgeries a year. So Netradhama is a group of eye hospitals in South India, which was founded by Dr. Sri Ganesh, our chairman and founder, 30 years back. Our motto is Shraddha hi Paramagatihi. So Shraddha means dedication. So we're very dedicated to providing excellent surgical outcomes to our patients. So technology has always been our tradition. We are the first movers in bringing new technology to the country and to our practice. And we were the first NABH accredited eye hospital in India. The patients that we typically offer diffractive trifocals to are patients with a more active lifestyle, patients who do a lot of near activity as well, so patients who like reading a lot, people who like doing intermediate work on their computers or their laptops, long hours of screen time, patients who do a lot of sporting activity where they cannot wear spectacles, and generally patients who are highly motivated for spectacle freedom after surgery. A very important question to ask patients is about driving, and especially night driving. But with the differential light distribution lenses like the geometric plus pairing approach, we do find that on the subjective questionnaires, patients are much more comfortable with night driving at about 3 months. So when a patient visits Netradhama, we try to make the experience as seamless as possible. The first thing that is done is the biometry. It's very important to do the biometry first before any drops are applied and before any other tests are done, because we need a pristine tear film for accurate biometry. And this is very important in premium IOL practice. You need to learn your patients. You need to spend time with them, learning their activities, their lifestyle, their preferences, their personality. We have a questionnaire. Any patient with an astigmatism of more than 0.75, we implant toric lenses. So this also ensures that we have good refractive outcomes after the surgery. Another very important preoperative test that we do for all patients undergoing trifocal lenses is the angle alpha. Every patient needs to undergo a specular microscopy and a OCT macula. We also do a screening for topography. The biometer comes with an inbuilt CT or corneal topography. This is more like a screening. So on that screening, if there is any red flag, the patient undergoes a complete topographic scan to make sure that everything is okay and it's not an irregular cornea that we're operating on. Now, abrometry can be important in irregular corneas, especially post-LASIK eyes or post-refractive surgery eyes, where you really want to see how the light is behaving through that cornea. So once all the scans are done for the patient and you have all the patient data, this is directly transferred into a software where the surgeon does the surgical planning. So what we target is that the sphere should be within 0.25 diopters and the cylinder should be within 0.5 diopters. So for advanced IOLs, this is a very important target to hit. We have a system of rotating tables where the laser part of the cataract surgery is completed and then the patient is moved to the assistant who prepares the eye before the cataract surgery, and then the patient is moved to the surgeon who performs the cataract surgery. So this way, the movement of the surgeon is minimal. The surgeon, the screen, the phaco system, everything is stationary, and the patient is coming to the surgeon very efficiently one by one. That all the surgeons at our practice have trained under Dr. Sri Ganesh. So this training ensures that they have a certain surgical algorithm in mind. So how do you complete your surgery in a short time without being in a hurry? It's very important not to repeat certain steps multiple times. The less you touch tissue, the less inflammation you cause. So that is why it's important to complete the surgery in a certain frame of time. So for advanced IOLs, we do prefer using laser-assisted cataract surgery. This allows a very standardized overlap of the capsulotomy over the lens, and it allows a shrink wrap effect. And it provides a more standardized effective lens position as well, which is not very predictable in certain cases. However, when you're doing a manual capsulotomy, you can also get an excellent outcome provided you have the right surgical technique and experience to get the standardization of the capsulotomy right every time. So if it's a very reproducible capsulotomy, even when done manually and when done in the right manner, it can provide a very similar effect as laser cataract surgery. For very soft cataracts, I prefer a mechanical chop technique. This is where I don't use any vacuum or phaco energy while doing the chop, and this allows for a safer surgery. The instruments come together and separate the soft lens, and it's easily aspirated. In a lot of ways, standardization included, preloaded IOLs are the way to go. So the multi-cert injector from HOYA is one of the most versatile injectors I've ever used. It's so easy to use, it's extremely smooth. You can use it either as a push type injector or a screw type injector, but I really prefer using the push type option because it does give me a lot of control. It's never gone in too fast. It is very smooth while injecting. And the beauty of it is the nozzle itself. So they have a beveled nozzle. What I do is I generally insert the nozzle all the way in because I like putting the IOL directly into the bag. When you have a cartridge that so easily fits into an incision without distorting the incision, causing any folds in the cornea, then not only is it very comfortable for the surgeon, it's comfortable for the patient intraop as well. You don't need to give them additional instructions to keep looking at the light. You don't need to force them. An assistant doesn't need to adjust the position of the eyeball. Everything fits, it goes in very smoothly, and it gives you excellent control. Also, for a post-operative refractive outcome and post-op recovery, it doesn't distort the lip of the wound. So this is really important in astigmatism control, where you're trying to give a good astigmatic outcome to your patient as well. Of course, in a 2.2 incision, it doesn't matter much, but the distortion of the wound, the folds on the cornea, all these are subtle small things that really matter in advanced IOL surgery. So in the geometric lens, more light is distributed for distance vision. About 50% of the light is distributed for distance vision and less light is distributed for intermediate and near. But in the geometric plus lens, about 36% of light is distributed for distance and more of the light is distributed for intermediate and near. So this is a differential light distribution approach where even high myopes can have excellent near vision. So patients have better intermediate and near vision with this pairing approach because light is distributed well enough for intermediate and near vision as well. So this pairing approach has really given us excellent outcomes in terms of quality of vision, even with the diffractive trifocal IOL. Outcomes as good as 92% of our patients are within 0.5 diopters of a spherical equivalent. So today we're seeing a lot of changing trends and growing demands for spectacle independence. And thank you for coming and taking a glimpse into our practice to see how we meet these demands. I hope these little tips were really helpful for you, and I hope more and more surgeons transition to an advanced IOL practice to give your patients the best possible outcomes.
So I think this is for Supriya and Eric both, and Supriya, you choose to use two complementary geometric IOL designs contralaterally. The first question is whether you also do it simultaneously or sequentially? And how does this compare to other trifocal options that you have used also?
So, ma'am, in our practice, we do it sequentially, not simultaneously for most patients. Of course, for a few patients, in special situations, we can offer simultaneous procedures, but our standard practice is to do it sequentially, maybe after 2 to 3 days. And like Dr. Ganesh said, the first eye, we always implant the geometric lens, which has better light distribution for distance. And the second eye, we implant the geometric plus. Now, how is this different from traditional trifocal lenses? In any other lens, trifocal lens, the light distribution is similar in both the eyes. So in both eyes, more light is distributed for distance, which gives you a little lower quality of vision in terms of contrast, brightness, and quality of vision for intermediate and near. So this is where this pairing approach comes in, and you have a fairly well-distributed light pattern for all distances. So patients are more comfortable even for near work and intermediate work with these lenses. And of course, night vision is also better because it's in that 3.2 millimeter zone in the center. The diffractive rings are only in that zone.
So I think as far as the role of diagnostics is concerned in patient satisfaction, Eric highlighted very well. Eric, I have this question for you. How do high volume surgeons ensure the reproducibility in results?
The thing is, the pre-op diagnostics, as was also pointed out by Supriya, is extremely important. You have to do all tests before surgery and for all patients, taking great care in doing the IOL master or a biometer as the first measurement ever, because when you have dry eye and you measure the decay readings, in many cases you end up with a fault measurement of decay readings. So also comes into play is we do in all patients all corneal topography, and we take a look at the epithelial thickness map. When we see an abnormal non-invasive break-up time or abnormal epithelial thickness map, we do not trust the measurements with our biometer. We treat the ocular surface and we let the patient come in 4 to 6 weeks later. I have a lot of patients showing half a diopter or more difference in between those two visits. So meaning, as was pointed out earlier, that you need to be within half a diopter of sphere and half a diopter of the astigmatism to have satisfied customers, satisfied patients, and good refractive results. So for all patients, do all measurements, so meaning corneal workout, biometer, dry eye testing, and also looking at the retina, of course, to have a full vision of that eye before you will do a full range of focus IOL implantation, and also order those lenses to get a consistent result. By doing that, we reduced our retreatment rate from 11% to nowadays 3%. We still have retreatments, of course, because there is no perfection in our world. Medicine stays medicine. It's not an exact science. So, but we reduced from 11% to 3%, which is for us a huge step forward in our patients' satisfaction scores.
So thank you, and now let's turn our attention to another condition that often becomes an important stepping stone for cataract surgeons on their journey towards mastering refractive surgery. To guide us to the Eye Foundation's approach to astigmatism management, we now turn to Dr. Shreyas Ramamurthy, again a young ophthalmologist and a leading expert in cataract and refractive surgery. He will share insights on why toric intraocular lenses are the secure choice for precise and stable vision correction, highlighting the importance of rotational stability and diagnostic precision in achieving superior patient satisfaction. Dr. Shreyas Ramamurthy is the director and a leading cataract and refractive surgeon at the Eye Foundation India, who specializes in toric IOLs, presbyopia correction, and advanced refractive procedures. So Shreyas, what's your approach to astigmatism management at Eye Foundation, recognized for maintaining high standards, affordability, and consistently delivering excellent clinical outcomes to a broad range of patients. Can we have, yes.
Hello everyone, I'm Dr. Shreyas Ramamurthy from the Eye Foundation group of eye hospitals. I'm a director here and as well as a practicing cornea, cataract and refractive surgeon. So the Eye Foundation has always been known as a front runner in technology, delivering quality eye care by using appropriate technology, but at the same time being very affordable. And that is a key mantra that is there in every person in this organization, that we have to be affordable. We should be able to deliver quality eye care with the best of technology to the entire gamut of society. Today, we stand at 25 eye hospitals spread across Tamil Nadu, Kerala and Karnataka. The expectation of the patient as well as the caregiver is such that we have to achieve optimal results comparable to what we achieve with refractive surgery itself. After the registration, they first undergo a basic vision testing and refraction by a well-trained optometrist who then does a slit lamp examination. The first thing that a patient undergoes is the optical biometry, because the essence of the cataract surgery and its outcome will be determined by how accurate our optical biometry is. Based on the results of the optical biometer, the patient then goes to a counselor who's essentially a senior optometrist. When the patient has a significant astigmatism, in our practice it's around 40% of patients, an aberrometry, a Scheimpflug based topography, any eye trace like equipment which gives us a function of the internal index of the eye, a dry eye assessment which is also done looking at the tear meniscus, the tear breakup times, all these investigation results. We then have a discussion with the patient, talk to them about what is afflicting their eye. We also have a detailed discussion about their day-to-day needs and their requirements, and ensure that we then tailor make the intraocular lens that the patient wants to choose based on their requirements, and the entire guidance and counseling then proceeds in this fashion. The aim of the surgery itself is really to debulk the amount of astigmatism that the patient has. For this, there are two important criteria that we look into. The first being the amount of astigmatism that we need to correct, that is the magnitude of astigmatism, and this we try to corroborate with at least 2 or 3 different devices. The second and the more difficult thing to achieve is the vector itself, that is the direction of the astigmatism. The direction of the astigmatism, if it is correlating in 2 or more scans, these are the patients who do extremely well with a toric intraocular lens implant. And in those patients, we go ahead and correct the full astigmatism that the patient has. Once this is corrected, the patient's quality of vision improves remarkably, and you will see that their best corrected visual acuity is actually much better after the cataract surgery than what the patient had even prior to the onset of cataract. Rather than using the word toric itself, we talk about customizing the lens for the power of their eye. So really, it is a customized lens where we are correcting the spherical power, the cylindrical power along the axis that the patient's cornea requires. Today, if you go online, you have a variety of wonderful calculators which are available. You have the Barrett toric calculators. HOYA has a wonderful toric calculator which also uses the Abulafia-Koch regression formulae. If you're using any one of the online calculators and you have only the anterior corneal measurements and you don't have a posterior corneal measurements either from your IL Master 700 or any Scheimpflug device, it really doesn't matter. Because there are multiple studies today which have shown that by just using the anterior corneal values along with the mathematically derived posterior corneal measurements which are input into the formula give you very accurate outcomes which are similar if not better than the measured values from the posterior cornea that you're taking from different Scheimpflug devices. So in our centers, we have certain preoperative equipment which are available. We take the different landmarks of the patient's eye, which are then wirelessly transferred onto the microscope, and we can see an overlay while we are implanting the lens. However, you could also do accurate measurements on the slit lamp where you mark the 0, 180 and 270 degrees. You can then mark the axis of implantation accurately, and then go ahead and use this manual marking as a guide for toric IOL implantation itself. All you have to do is ensure that you have accurate measurements on the slit lamp, either with a marker pen or just a small scratch on the cornea with a 26 gauge blade, and then subsequently once you mark it, refresh the marks on the operating theatre table, and you can have extremely accurate outcomes even without using a markerless system. Consistency comes from when the patient is made to lie down on the table, where the sister who's actually draping the patient explains to them about what is going to happen to them over the next 10 minutes, and then subsequently standardizing your procedure, the way you do your incision, the type of incision that we use, the type of phaco tip and sleeve that you use is all dependent on the intraocular lens. And this is where a very good injector system like the Multicert, which goes very smoothly through your incision, it enables you to easily deliver the intraocular lens in the bag, but at the same time ensuring that you don't have to do a difficult wound assisted delivery, but it slides through a 2.2 millimeter incision, and actually you have the mouth of the cartridge very much over the pupil and the IOL is going directly into the bag. I'm quite fond of the Vivinex toric lens. The rotational stability of the lens is excellent. The tips of these lenses, the haptics, are also sticking to the bag very well, and the rotational stability is extremely good. So a combination of an efficient delivery system with a very rotationally stable lens makes this a very preferred choice for many surgeons. Using Vivinex and eye foundation has become an integral part of ensuring that we are able to deliver the quality care that we want to use for our patients. One important tip which I would also like to add is ensuring right positioning of the lens, not just when the lens is implanted, but after you remove the viscoelastic, after you hydrate, after you remove the speculum. Because each of these maneuvers can cause change in the anterior chamber dynamics, the deepening or the shallowing of the anterior chamber which could happen in any of these maneuvers, which could lead to a rotation of the intraocular lens. I hope this video goes in furthering the adoption of correcting astigmatism in our patients more as a necessity rather than a choice. We are also encouraging surgeons to ensure that they are able to deliver excellent results to their patients with confidence, and also ensuring that we are able to enjoy the whole experience of doing cataract surgery in these patients by using the multitude of IOLs, the array of IOLs that is available on this platform. Thank you.
So thank you, Shreyas. I think that was a very useful tip. One, that is at all steps, right, from when you have implanted the toric intraocular lens and you've closed the eye, you need to see that the lens is still there. This is for Professor Trityal. So what is the prevalence of astigmatism in your clinical practice and across India overall? Mike?
It's a difficult question to answer. Across India, I have no idea. But I can tell about what is my experience in, when I was in RP Center. I think, one thing which has changed the life of surgeons and life of patient in cataract surgery has been the introduction of toric IOLs. Because we have been struggling to correct the toricity of cornea when we should do cataract surgery, and think about other measures to correct this astigmatism, which maybe arcuate keratotomy or LRIs. They were not very predictable. And since this toric IOL has come up, it's made life easy for all of us. If I see my journey before 2010 or so, and my toric IOL induction would be around 10 to 15%. Now, if I look into 2020s, my toric IOL amount ranges 60 to 70% of my cases. Why? Mainly because of introduction of these newer generation lenses, where the little bit of residual astigmatism can take away all the advantages. You all understand that. And therefore, if you have people with less than one diopter cylinder, which Supriya talked about that, it's necessary to correct that also. The toric dimension has increased, and its use also has increased, and its advantage, we all know how effective that is. So I say in my practice as such, it has been 60 to 70% of my cases are toric. In some of my OT lists, sometimes it is 90% also. So it depends how you see your patients. As one word I take from Supriya, I said, we have to understand the patient. I think that is one of the word I picked up today, because if you understand your patient, you can manage the patient better. And that not only because of your investigation, it is your acceptance of knowing the patient right from the he or she, how does they approach their post-surgery, their rehabilitation. That means type of work they are going to do. That is very important. And not only for trifocals, if you are going for ERB lenses, EDOF lenses, the toric part has to be there. And what we talked about stability, I think that is a design which has made huge difference now, where stability is very important. Even a 3-degree to 7-degree rotation can make a huge difference in these multifocal, trifocal lenses. I think it's a very significant change which is happening in our practice, and that we have to look into. And people who are doing toric IOLs, most of them may be doing a manual marking also. Even that is effective if you do more correctly. Adaptation of yourself to those markings also important. Don't leave it to other person to mark for yourself. And if you have access to a image-guided system, nothing better than that.
So, what are the strategies that you think one should embark on to increase the adoption of the toric intraocular lenses?
That's a very good question, Professor Namrata. I think, across the country, sometimes, people have a hesitation that toric surgery may be difficult. In fact, it's not difficult at all. It is same as what routine surgery you've been doing. If you are doing a good surgery, it's same. Only thing different is the intraocular lens has to be put in the axis of desirable area. That is the steeper axis of a corneal astigmatism. The importance there, which we have been highlighted by both Shreyas and Supriya, is to do a biometry as a first step investigation for your patients. Your cornea should be virgin when you are doing all these analysis. And there you get the actual amount of toricity in the cornea and axis. And whatever we have been telling in that is, when you are looking to corneal toricity, when you are mapping the cornea, use at least 2 or 3 instrumentation of a different principles. And that gives you idea. If your axis is matching, the cornea is regular. If the axis is matching, the cornea is regular, you are pretty safe to implant this case. If your axis is getting different more than 10 degrees, there's something wrong there. Either ocular surface is poor, or you have touched the cornea before you take this investigation. In that situation, put an artificial tear, call the patient again and see it. Whenever there's a variability in your readings, make sure you get the patient multiple times to get the same readings. And it is always safe to have a regular cornea with investigation. Second important part is, as I talked about, once you know what is the axis of your implantation, the markings are very, very important. That can be done in the slit lamp with your experience. It can be done by various other means. You can use, if you're using manual things, bubble marker are the best ones to give you a good horizontal appreciation. If you have 3 marks, 6, 9, 3, 9, and 6 o'clock, it gives a nice orientation to put good markings there. But I think it is the understanding of your surgical skills to put a proper marking and proper placement. But if you have access to various devices, nothing better tthan that. We have now femtosecond laser devices, which can also give you a marking in the anterior capsule, apart from the other ways, and that is also simpler. So it's not very difficult. I would say it's very simple, and go for toric IOLs. If you are doing a monofocal lenses, anything more than 1 you should correct. If you are going for trifocal lenses, anything less than 1 also you have to look into. Other thing which is very important for our trifocal lenses is to understand the total corneal astigmatism. That is taking care of both anterior and posterior corneal curvature. Because we all know the posterior is always against the rule. If your anterior is also against the rule, you are going to always undercorrect. If anterior is with the rule, you are going to overcorrect. So that has to be taken into consideration. Formulas which takes into consideration of posterior corneal curvature will always be better for you. So look for those important points.
So thank you. I think that was a very useful suggestion. If there is a mismatch in terms of the axis of astigmatism, then you need to verify again. There's another aspect to it. If you have 2 or 3 instruments and there's a mismatch in the K value, then which K value will you use for IOL power calculation? Dr. Tityal, sir? Mismatch in the K values amongst 2 or 3 instruments, then what is your go-to K?
That can happen in a difficult situation like a post-refractive surgery eyes, especially a radial keratotomy patients, or a patient who has ectasia like keratoconus eyes, keratoconic eyes. The basic idea there is to know the 2-3 things are there. One, as I said, maybe because of your way of investigation. But if you're done correctly, despite that you have a mismatch, then you have to take one of the instrument which is more reliable. So maybe I can go for either pentacam or a anterion, which can give a good profile of your cases. And if even that is little misleading, if I have 3 readings from 3 different instrumentation in a post-refractive surgery, I'll always take the flattest K amongst all these for our calculation IOL power, and that will safeguard yourself.
I think again that's a very useful tip, that you take the flattest K if you have a mismatch in your Ks amongst various instruments. So the next question is for Dr. Richard Peckard. From your perspective, what strategies can we employ to further drive the adoption of toric intraocular lenses? And how do you think the visual outcomes correlate with the patient satisfaction? Dr. Richard?
Yeah, I come from the United Kingdom, as probably you know, and we have 2 patient populations there. They're the patient population that have their surgery dealt with under the National Health Service, and then there are the private patients. And the incidence of toric lenses is completely different between them. There's a cost issue as far as the National Health Service is concerned with the various lens companies. So what is happening at the moment is some hospitals are negotiating to have a proportion of toric lenses and are putting them in, but there's actually quite a feeling amongst many of the surgeons that they can't be bothered to go down the toric route because the lenses are not readily available. In the private sector, it's a completely different matter because the majority of patients there will be trying to become more spectacle independent. And in that situation, you have an obligation to provide toric lenses and know how to put them in. In order to get more people to put toric lenses in, I think education for surgeons is very important. We've heard some wonderful points today about astigmatism. We all know that if you can give a patient a really good correction with a toric lens to deal with their astigmatism, that they're going to be much happier. But again, their perception depends on what you said to them in advance. And providing that you haven't oversold, you'll almost certainly have happy patients. I think that across the world now, toric lenses are being used more, particularly where people are using lenses for multiple corrections. So if you're using a lens that is for presbyopia correction, you're going to need to correct the astigmatism, which is the final question here. As far as my threshold is concerned, I would say that if you're putting in an EDOF lens, a trifocal lens, that a half a diopter is to be corrected. Graham Barrett did an interesting study with monofocal patients where he was using monovision with these patients, and he corrected half a diopter. And he said there was no question, as far as the patients were concerned, the responses that he got back from them, that they were very happy to have even this small amount of astigmatism corrected for the quality of the life that it gave back to them.
I think we are all on the same page that the toric IOLs have to be corrected.
Can I just put a question to the audience here, sitting here? You have, I see a lot of different generation of people sitting here. So how many of you are using toric IOLs in your routine practice? Can you raise the hand?
So almost everybody.
Almost 90% of people using toric IOLs.
So
how many of you have toric IOLs more than 20% of your list? Around 30%. How many you have more than 50% of your cases toric? Only 2%. So don't sit down. Look for your patient. Correct. As Richard said, even a 0.5 diopter makes a huge difference in your cases. Try to correct astigmatism as far as possible for your patients. Thank you.
So I think when in spectacles we correct toricity and we never leave a patient just on a sphere, we always give a cylinder. Likewise, why leave a patient just on sphere and make the patient, just correct the sphere? So toricity, even intraocularly, has to be corrected just like we do it extraocularly, whether it is with contact lenses or with spectacles. So this question is for Shreyas.
Just one question. Those people who are not using toric regularly, do you think the cost is a major factor? Raise your hand. 90%. I request all the companies who are making toric eyewears, the cost should be as, spherical lenses. Your acceptance will be 100%.
No, there is another thought that maybe for low cylinders, the cost should be almost equal to that. Maybe for higher cylinders, you can keep it, but if you have a cylinder up to 1.5, if that is, then that will make the difference between the 20% to the 50%. So
I think that is in the mindset of our people in India. The cost is a major factor, because I've seen in places like All India Institute also, if I have a spherical lens and a toric lens, it's 2.5 times costlier than the spherical lens, which is a deterrent for most of our patients. So that can be one area we should look into.
So I think
just one point is that when you're doing the biometry, you should always do the biometry for a toric lens.
Yes.
And the biometry will tell you whether a toric lens is required or not. Because many of them may be wearing spectacles without astigmatism, but when you do a calculation, it will show you that the patient needs a toric lens. And we tell the patient that, see, the scan shows that you need a toric lens. If you don't use a toric lens, your vision is not going to be good. So if they say, no, I don't want a toric, then we take a negative consent, saying that you've been offered it and you have refused the toric lens.
So I think, that's a very good point. I've had many patients who are not using, a cylinder in their routine life. The one we did a biometry, it showed a cylinder. I said, okay, toric lens has to be put to correct your. And they were saying, no, why should I get a toric lens? Because I never used no cylinder in my glasses. So I think there is a counseling which is important for these patients also.
So another question from here is that if they've never used cylinders in their spectacles, do you find, because they are not used to it, and if you correct them with toric intraocular lenses, do you think that there would be concerns of adaptability in these cases?
Yeah, I think that's a good concern. There are two things there. If patient was not using cylinder before in younger days, now patient has a cylinder subsequent life. That means there has been either a corneal cylinder addition or a lenticular cylinder coming up these patients. Because as the cataract grows, sometimes there is a lens-induced cylinder comes up. And if you do, as Sri Ganesh said, if you do a good biometry, that will tell you, because that's going to take only the corneal part only. We are correcting only corneal cylinder. We are not correcting the total cylinder, which is covered by the other areas.
Yeah, I think
that should be important.
That's an important point, that you have to distinguish between the lenticular cylinder, the corneal cylinder, and the total cylinder that is there.
No, but one other thing that you have to distinguish is with the rule versus against the rule. So you have to be less forgiving or more forgiving depending on whether it's with the rule or against the rule, because a little bit with the rule is helpful.
Yeah. So Shreyas, the next question is for you. Could you comment specifically on your practices around double checking the magnitude and axis of astigmatism?
I think, like already was mentioned in the video and by Titial sir and the previous speakers as well, that it is important that we have a way of standardizing our measurements, because frankly, with the way surgery is done today with markers, whether it's manual or markerless systems, it's very often that we'll get the surgery on point, and the IOLs itself, the power and the direction, the vector are all very accurate. So most often, if you have a post-operative refractive surprise, it's really to do with the preoperative biometry and very little to do with the surgical process itself. So when you're doing the pre-op biometry, like was already discussed, I think what we really need to keep in mind is ensuring that biometry is your first test that you do, that even before a dilating drop or paracane or any other drop is instilled, which can affect the tear film dynamics and can cause some punctate erosions on the cornea, which can significantly affect the measurements. Now, cross-checking again is also to ensure whether you are getting the right measurements or not. Looking at the Myers or training your, if you're not doing it yourself, obviously training your optometrist or technician to ensure that the quality of the reading that they are getting on each instrument, the quality of the Myers, the completeness of the Myers that they are seeing is very, very important. Now, very often we will get magnitude which is similar, but getting the direction, that is the vector of the astigmatism, can be different from one instrument to the other, especially based on the way it images each of these the corneas, based on the imaging principle of the device itself. But suffice to say that once you have a patient who has a direction vector which is similar across 2 or 3 devices, then these are patients who are going to do extremely well with your toric intraocular lenses. Patients who have some amount of irregularity, we have used toric IOLs, we are using them regularly even with keratoconic patients, post-graft patients as well. But here the idea is really to debulk the amount of astigmatism. We are not really looking at emetropia here, but debulking the astigmatism, especially in the higher diopter of cylinders, really improves their best corrected spectacle visual acuity, their quality of vision. So even though some may say that if you can't get an accurate measurement, why do a toric IOL at all? That's really not the case. Higher the cylinder, more irregular the astigmatism, debulking the astigmatism itself significantly improves the quality of vision, unless the patient is going to be wearing contact lenses in the post-operative period, which is seldom the case in a country like India, where a patient at age 60 or 70 is going to be wearing a contact lens. So debulking astigmatism, even if a small residual is left in their glasses, the overall quality of vision will be much better.
Okay. Thank you. And I think the next question is going to be on the rotational stability of the lenses.
Sorry, Namrata, I got something in mind. Let me ask this question to Sri Ganesh, because he has a huge experience for our audience point of view. He talked about geometric and geometric plus. I know that geometric plus may not be a good idea in a patient. But what about geometric in a patient? Does it do better, or you always have to have a geometric plus?
See, I always go in for the pairing approach because I think this gives the optimal kind of a result for the patient, optimal light distribution. Suppose the patient, and I always do geometric first. If the patient has a longer arm, reading distance is much longer, taller patient, then you can put geometric in both the eyes. If they prefer better distance vision, then the light distribution is more for distance and intermediate. Near, there is a little bit of compromise, but most patients want good distance, they want also good reading today. Many of the older patients, they want to read well, and some of the trifocals don't offer good reading, which if you put a geometric plus in the other eye, they will get good reading.
Okay, I think point is made clear. Yeah. Sorry, Namrata.
So, no, it's okay, sir. So I think a quick comment, because we have the next movie to do, and that is about the rotational stability, more so in myopic eyes, both for monofocal and for multifocal. So I think Shreyas did allude upon it, saying that one has to be careful at all steps in time. Eric, would you want to comment on it?
Especially in the high myopes, I would avoid the plate haptic IOLs. I would go, the geometric platform, the Vivinis platform has proven to be very stable in those cases. Make sure that you use like the Barrett toric calculator or the Evo toric calculator. We also measure the posterior corneal astigmatism as well. And also the surgical step, make a very good capsulorhexis, that they have coverage 360 degrees of the optic. And make sure also to remove all the OVD behind the IOL, especially in those high myopic patients. And also consider a capsule tension ring in many of those cases.
Thank you. So continuing with the theme of surgical excellence, working out of Chennai, India, Dr. Ashwin Agarwal is the Chief Clinical Officer at Dr. Agarwal's Eye Hospital, an eye care group spanning over 170 locations globally. What is outstanding about him is that he's mastered a remarkable range of procedures and is able to handle a high volume of challenging cataract cases with skill and precision. So we would like to play his video where we will witness a range of challenging cases and will gain some practical tips that can be applied to routine cases as well. So can we have the video, please?
Hi, my name is Ashwin Agarwal and I'm the Chief Clinical Officer for the Dr. Agarwal Group of Eye Hospitals. Agarwal Eye Hospital is basically 194 centers spread across India, 180 and 16 across into Africa. We've taken ophthalmology to the doorstep of the people. Basically work on a hub and spoke model as patients coming in from the satellite centers into the hub, or any challenging complex cases that need supervision or need expertise come into the main hub. In my personal practice, I'm dealing with cataract patients, cornea patients, refractive patients, glaucoma patients, and the most important being complex and challenging cases. So in my center alone, we're seeing about 700 to 800 patients a day. And if I'm seeing 700 to 800 patients a day, number one, I need doctors. I need to empower my team, my staff to actually deliver the results, number one. Second, time management and efficiency. Applaud and I recognize them for their, whenever somebody does really good on their time management and efficiency. Learn that, make it a standard operating protocol and share it with the others. And you're always there to serve the patient. That availability of time from your side, personal touch added to it, brings a huge amount of trust. Some of the tips and tricks that you got to use some basic principles in any of these challenging cases. When you see a coloboma in the Kansky book or a picture, it looks beautiful. But actually when you are working on a coloboma patient on the table in the OR, along with the phacoemulsification probe, you're also infusing BSS through the zonules or the weakened zonules in this scenario. That BSS goes behind the bag and into the vitreous cavity. It now hydrates the vitreous and causes a positive pressure. What I started to do, and I'm proposing this as vitrectomy assisted phacoemulsification, is to pre-place a trocar behind the iris before the case even began. Now what this does is, while I'm doing my phacoemulsification, if I have positive pressure, all I have to do is use a vitrectomy cutter, go behind and do a dry vitrectomy at 1500 cut rate, port down so that you're not touching any of the capsule, just for about 7 to 8 seconds, and now come out. What you will get is a deepened chamber, and now you're protecting your endothelium, you're protecting the posterior capsule, you're protecting any vitreous from coming into the anterior chamber. A lot of protection mechanism just by doing a 7 to 8 second dry vitrectomy in these scenarios. You could use this same vitrectomy assisted phacoemulsification in multiple reasons. Aqueous misdirection, intermittent cataract, high pressure glaucoma patient with angle closures, multiple reasons where you could use this. In intraocular lens drops, there are different types of intraocular lenses that can drop for multiple reasons. When they drop on the retina, the old techniques that people used to use was using intraocular lens forceps. But remember, the forceps were not made for intraocular lens drops. They were made for holding intraocular lenses and doing sutures or something like that. Now what happens is, when you have, for example, a plate haptic lens on the retina, the forceps works in a principle which is like coming up, it closes while coming up. So you actually have to go deep into the haptic and then hold. So only when it comes up. Now this small trick changes the game when you have a plate haptic lens. When you have a plate haptic lens and a forceps that works on the upward motion of its closure, it would not work. And that's what I faced. So I started to do something called as the extrusion cannula assisted levitation. It has a silicone sleeve inside. All I did was remove that silicone sleeve. Now that made it a wide bore lumen with a metal rod. Now all that I have to do is go on top of the optic, nowhere going close to the retina at all. Obviously all this is after doing a core vitrectomy thoroughly. Go on top of the optic and just aspirate the foot pedal at 400 mm. When you aspirate that, it would stick to the optic just like a fish and a spear, and it would bring that fish all the way up into the anterior chamber, and you can explant it or you could cut it the way you want. So in zonular dehiscence, when I'd see a zonular dehiscence, if it's a traumatic case, which is the most easiest, I would look at the amount of clock hours. If it is anything less than 3 clock hours, I would do a simple CTR or a capsule tension ring and put the lens in the bag. Anything more than 3 to 6 clock hours, I would place a segment, a Ahmed segment into the eye and attach it to the sclera using a double flange technique. Anything above 6 clock hours, I usually tend to do a glued intraocular lens. It is far more stable in an eye for 10 years out, and I've got 10 years of record to show that glued IOL in these scenarios are far better than doing 2 segments. If I have a completely dislocated bag, that means more than 8-10 clock hours, I would definitely just ECC that whole lens and definitely do a glued intraocular lens directly instead of trying to save the bag. Nowadays, I do a biplanar incision along with a small Wong pocket. Excellent tip, because now I have 3 ports of doing stromal hydration. One is inside the Wong pocket, 2 of them are on the side of the wound. What that does is it presses on the upper lip of that wound downwards as soon as I hydrate that Wong pocket, and the 2 sides of the incision, if I'm hydrating that, it covers the other 2 sides as well. This has a very, very nice approach. 1 for the wound leak, 2nd for the astigmatism that I might cause at the end. The most annoying situations for a surgeon is when they have finished the phacoemulsification and they are placing the lens thinking the case is all over, and now you have a problem because, oh my god, the lens loading was not right, or because I had an infection because it was not loaded really well. Having a safe delivery system for an intraocular lens is probably the lowest hanging fruit available for us surgeons. If there is one system that has changed the game completely, it is definitely the multi-cert. Revolutionized the way that we are doing even the premium IOLs, even the monofocals, even the enhanced monofocals, all of the above. Treating a standard patient for a standard intraocular lens, we were treating them with just monofocals. But going forward, looking at the amount of screen time that people have, looking at the importance that is being given to vision in all the distances, practice of doing enhanced monofocal has to become standard practice. It could come to a day where you might see only enhanced monofocals from all being implanted, and Impress being a really good one from the lot. Well, I really hope that this video was extremely beneficial for every person who's viewing this. I think that there is a larger vision that everybody in the audience wants to address, and that is of building trust within their own community. And when you build trust within your own community, you'll start seeing that benefit come back to you in multiple ways and from every corner. So thank you very much.
So thank you, Ashwin, for that, for those great tips. And you did mention about the enhanced monofocals. So what in your practice is the percentage of use of enhanced monofocals, and what would you like to say about it?
First of all, thank you, ma'am. I think you've been conducting this event extremely well. It's such a well-managed program, and all the questions are so realistic, you know, and it's tough. And all the speakers, really, every time I hear them, I kind of learn. Eric, Supriya, Shreyas, and panelists, unbelievable. Thank you so much. I know we're leaving the best for the last, so we'll come to that, Richard. But in my mind, what's happening right now, ma'am, is that a lot of, and we don't call the shots, right? It's actually the patients and the
their lifestyle that actually calls the shot in this scenario, especially looking at enhanced monofocal or it be trifocal segment. How it's been growing is purely a sign of the lifestyle change. And when the lifestyle of the general mass audience kind of changes from distance viewing to intermediate and near, which is what it's become, everybody is, I mean, just open your screen time on your phone and you'll know you're spending at least 4 to 5 hours on that device. And anytime you're bored, you're in it. So you're actually spending a lot more time. So even if you're not deciding that, and that's what's really happening. So when that starts defining it, we as doctors, industry as makers of these IOLs, start listening to this thought process, and that's what kind of changed our practice as well, especially when Zoom came into effect and when we started having Zoom calls a lot more, when we started having digital exposure a lot more. It changed my practice to about 20% increase, at least in the enhanced monofocal, and that was in just year 2 after COVID. Now it's about 35 to 40% increase in enhanced monofocals. In fact, even a patient who was willing to go for probably a monofocal is now coming and saying, hey, I heard about this from one friend of mine, and why don't you give me that option? And that's how this whole gamut kind of changes. I do believe that we are moving towards that segment because it has less glare, halos, and all the other side effects of the trifocal. So the low-hanging fruit for us as doctors as well as patients is that segment that we can easily offer this and get through. When it comes to trifocal, there's a little more counseling required. There's a little more hand-holding the patient through that experience required. So I would say 30 to 40% is where it has increased the enhanced monofocal.
Dr. Mahipal sir, can you do have extensive experience with the Impress technology, and are there any specific pathologies or comorbidities where you would rather go for standard monofocals rather than enhanced monofocal, or to say, what are those cases where you wouldn't do enhanced monofocals?
Thank you very much, Dr. Namrata. That's a good question. I think the basic strength of an enhanced monofocal lies in the fact that you can do it with your eyes closed, in the sense that I don't have to bother whether I'm doing a normal monofocal or an enhanced monofocal. I, in my practice, have about, if I leave aside the, even if you add the torics, Impress just now doesn't have a toric, but if I add another company's toric, I think about 85% to 90% of my patients go in for the enhanced monofocal. So that means that there are almost no contraindications for doing an enhanced monofocal. You don't have to talk to the patient about anything. The price difference is not too great, so it's a standard of care for me now. So I'm doing enhanced monofocals in almost all the lenses. It's very rare that I'm doing a normal monofocal. And the patients at times are very, very happy. They may not even need glasses except for fine print, but typically when you're looking at the Impress, it is offering a reduction of the ad from a plus 2.75 to about 1.5 or 1.75. That's the ad they have, and if you do it as a mini monovision from that perspective, they could be N8 and rare at times they can be N6. So to answer your question, I think I don't have any specific contraindications for these patients, which are any patient who comes to me for a cataract surgery and is not going for a trifocal or for an EDOF lens. No glare, no dysphotopsias, and you get reasonable, like what Ashwin was saying, what we are like on the smartphones, like Titial is on the smartphone just now, and you have the laptops. I think this is where it works well.
So 80% you said is enhanced monofocal, and you said possibly no monofocal or very few monofocals. Yeah. So that means 20% is your trifocal use, or is it more?
No, I think you're right on. My practice in trifocals or the EDOF, these two combined would be close to about 20%. I do a lot of LRIs for up to 0.75 diopters, so therefore my toric penetration is about 30-35%. Because a lot of patients fall within the 0.751 this thing, and I do have good outcomes with LRI.
So another question is that if in the fellow eye you have a monofocal or a multifocal lens, then can you implant?
Doesn't matter.
So you can implant.
That's again the beauty of it, that you can go ahead and do it even if you have.
So it's a great combination, mix and match lens.
Yeah.
You can match it with any other lens.
Yeah.
How do you convince your patients to pay more for this technology, and what promises do you make them?
I don't make any promise. That's my standard. My typical ATV for a cataract surgery is now 1,15,000. So so patients who come to me with eyes open, but in any case, see, the point is that that's the good thing. The first monofocal that came into the country, I happened to be on the global advisory board, and I told them, let's make it to the standard of care. So the difference between a monofocal and an enhanced monofocal was only 4,000-5,000 rupees. So there isn't much convincing or anything that you have to really ask them to do. Once the companies make a big difference, like for example, now you have an EDOF lens or you have a trifocal, and that cost is 4 times or 5 times, that's when you have to convince. But if the differential is only 30-40%, that's really not something. And patients are nowadays willing to pay, and it's not. It also depends on the type of practice that you have. So that's what it is.
Okay, so I think we've had a great panel, because what insights you have learned here are not written in books. Nobody tells you, and they don't come from didactic lectures, they don't come from surgical videos, but they come out of experience. And I think that way Hoya has done a great job by getting all the experienced minds on the panel. One last word from Dr. Sri Ganesh about micro mini monovision.
Yeah, I use the Hoya Impress, and you can do a micro mini monovision about 3/4 of a diopter to 1 diopter, and if you do this, then most patients would not require glasses. Most of them are able to read N6 at 40 centimeters in my experience, because the Hoya gives about 1 to 1.25 diopters of depth of field depending upon the pupil size, and then if you add another 3/4 to 1 diopter, then it's almost 2.25 diopters. So at 40 centimeters, they're quite comfortable reading. And this is a very good approach. Then they have spectacle-free vision, they don't have any dysphotopsias at night, and the patient satisfaction is very good. So you don't promise them that you can get rid of reading glasses, but you can tell them that I'll kind of make a little bit of adjustment in the second eye to help you see things a little better for near. And then when they're able to read N6 and don't need glasses, then they're thrilled, because they haven't paid so much as a trifocal, but they've got the benefit, and it works very well. Okay. Plus, I think it'll become the standard of care, because now you see so many patients post-LASIK who are coming in for surgery, and the advanced monofocals are a little more forgiving for small errors in biometry, and this actually also is an advantage over standard monofocals.
So a forgiving lens is always more, you can say, easy and for our comfort zone, and so that is also important. So now we are coming to the highlight of the session, and I'm truly honored to welcome Dr. Richard Packard, a distinguished surgeon and educator in ophthalmology globally. Dr. Packard has played a vital role in shaping ophthalmic education worldwide and is one of the key contributors to the new Masters video library. Today, he will introduce this cutting-edge educational resource, which is transforming how surgeons enhance their skills through video-based learning. May I have the video, please?
My name is Richard Packard. I come from the United Kingdom, and I have been involved in teaching cataract surgery for well over 40 years. My journey in ophthalmic education, particularly in the field of surgery, has been driven by deep passion for empowering surgeons at every stage of their careers. We all start with our journey to becoming a master as tyros, as people who really don't know what they don't know. And in order to become a master, you have to go through various stages of learning. It's important that you do these, so you first of all, after your stage of not knowing what you don't know, you then discover what you don't know, Then you learn how to deal with what you don't know so that you know that you can put it into action. And finally, when you get to the stage of mastery, you are at a stage where you have an unconscious understanding of what you need to know. In order to get to this stage, it's important to realize what the real challenges are in your surgery. There are physical challenges, there are mental challenges, but by and large, if you can break down any difficult procedure into small aliquots of training, of skill, you'll find that by doing this, you should be able, even at a relatively early stage, if you understand what you're doing, to be able to deal with more complex cases. You just need to get your mind in order, and you need to make planning an absolute essential before you deal with that patient. To deal with this as well you possibly can, I think you need to have the ability to be taught well in the operating theatre, but also to have access to high quality materials, videos online and so on and so forth, that are discussed by masters for your benefit. A few years ago, Hoya Surgical Optics got together with ISASO to try and bring forward a platform that would enhance the training of surgical trainees. Until now, Masters has essentially consisted of digital CME courses. There's been some face-to-face, there's been some wet labs, there's been a whole variety of different things to make the path for trainee surgeons better and easier and more successful. Now we're going to introduce something completely new, which is the Masters Video Library. That would enhance the way that the young people could be brought towards mastery in their field. And once they'd achieved that, then they would be able to join the program, of course, and assist in their way. But in the first instance, they needed to get to this stage in their career where they felt so confident that they could take on more difficult cases without worrying about it. It's a very special collection of curated videos, which have come from the Video Journal of Cataract, Refractive and Glaucoma Surgery, along with many other high-quality international contributions produced specifically for this library. Global masters that it features are also helped by the quality of the material that will be available to you in terms of the motion and graphic designs, which enhance the whole experience, that make everything more understandable and easier to learn. Within this platform, it is so easy to find relevant videos to your specific learning needs, and over time you can build up your profile and suggestions to further improve your experience and optimize time invested in self-learning through visualization. There's also structured navigation, where you can explore a well-organized library with categories and subcategories designed to streamline your navigation and discovery process, and view the videos which are popular amongst your peers so that you can understand through this means what is trending and what might be beneficial for your patient community. If what you've seen is something that would excite you, something that you feel would help you towards mastery in your field of ophthalmic surgery, then I would advise you very strongly to sign up and register, because I think you will see some significant benefits going to the future.
So thank you so much, Dr. Richard Packard, for your contributions to this. I would like to understand, for the benefit of the house, how is this resource different from others? Because you do have a lot of content which is present online.
I think this is a very important gathering together of videos. It's unique because it provides a truly video-based education, and the content itself is very credible. It offers you extensive, high-quality videos which are extracted from the Video Journal of Cataract, Refractive and Glaucoma Surgery, which, as you will know, was put together by Dr. Robert Osher, and that's been going for 40 years now. It's a wonderful archive. It also will be including original productions featuring from many leading surgical masters, and each video is carefully categorized and tagged. And that will enable you as surgeons to locate very easily what you want to use to enhance your specific knowledge, and it will make it then into a very powerful tool for you to become a better surgeon, to give your patients better outcomes, which is after all what we really want to achieve.
Who do you think would benefit from it? The learning surgeons or the experienced surgeons or the surgeons who want to, refresh their surgical skills?
I think it covers the field. I mean, there are going to be surgeons who've got to a certain stage in their career. Maybe they've done 100 procedures and they feel reasonably confident about doing routine cases. But then they're presented with more difficult cases. As I said in the video, the important thing about this and the training that you can achieve by looking at the videos in the video library is that you can break down a complicated procedure into small and relatively simple steps. And once you've done that, this will lead you forward to enhance your skills. On the other hand, if you're a more experienced surgeon and you maybe want to have a look and see, is there a better way of doing something that you had previously done and you would like to see if you can do it better, I think that this will provide an expert set of values that you can achieve. And ultimately, as I say, it'll make you a better surgeon and it'll give your patients better outcomes because you've gathered together the pearls that are available in this wonderful collection of videos.
So I would encourage all of you to sign up and utilize this exceptional resource and share it with your friends and colleagues. You can easily do it by scanning QR code on your popcorn box if you have got it. And if you have not got it, you can ask Hoya to give you the popcorn box which has the QR code, or anyone around you who has the popcorn box. You can share popcorn with your friend also. Or you can also join by typing mastersvideolibrary.com. I'm truly honored that Hoya has done this session and I've been invited to moderate this session. A sincere thank you to our outstanding panel. And like I said, what they have told you and they have taught you is not written in the books, is not there in the surgical videos, is not there in the didactic lectures, but comes out of experience and so many minds and so many experience and so many innovations and so many thoughts. So I think it has been truly a very enriching experience as far as this film festival is concerned. And Hoya continues to dedicate itself to education and continuous innovation in cataract surgery for providing the best patient outcomes. See you next time, and we do have some felicitations to do. So I would request Professor Titial to felicitate Dr. Eric. It's the other way around. Thank you, Eric, for traveling from so far and for sharing your insights and for your contributions. I request Dr. Richard Packard to give a token of appreciation to Dr. Supriya Sriganesh, our young ophthalmologist. Showed a great video.
Come in the front, no? Why they're there? Supriya. Come in the middle. Come here.
In the middle, please, in the center. Thank you, the audience, who's been a great audience, I think, and I'm sure this session would have been useful to everybody. Dr. Maipal Sachdev, to please give a token of appreciation to Dr. Shreyas Ramamurthy. Shreyas. Dr. Eric Martin to give it to Dr. Ashwin Agarwal. There is going to be a group photograph for the speakers and the panelists, so please do stay back. Dr. Sri Ganesh to please felicitate Dr. Richard Packard. Thank you, Dr. Richard Packard, for traveling from UK and for sparing your time with us. Dr. Eric to please felicitate Dr. Sri Ganesh. Eric. Shri Ganesh. Dr. Richard Packard to felicitate Professor Titial. Dr. Richard Packard to felicitate Dr. Mahipal Sachdev. Sir. Sir.
I'll request Dr. Eric to felicitate our moderator, Professor Namrata Sharma, the Chairman Scientific Committee. She did a wonderful job today. And request all the speakers, panelists, and moderator to come for a group photograph. And with Antonio, Paul, Jimmy, Yurul, Bipin, all of them.